Hello everyone. Today we are talking about the clinical features of gingiva. In the previous videos, we spoke about the microscopic and macroscopic anatomy of gingiva, keratinization and gingival fibers. So if you haven't watched them yet, you know what to do, right? Click on the link given below. So first we have the color. The color of attached gingiva and marginal gingiva is coral pink. Why is this color produced? The color is determined by three factors: vascular supply, thickness and degree of keratinization of the epithelium, and presence of pigment containing cells. We earlier saw that the mucogingival junction separates the attached gingiva from alveolar mucosa. This alveolar mucosa is red, smooth and shiny. Now why this difference? The answer lies in the epithelium. The epithelium in case of alveolar mucosa is thinner compared to that of the gingiva. Here it is non-keratinized, whereas in case of gingiva it is the keratinized epithelium. The alveolar mucosa does not have any retipex. The connective tissue is loosely arranged and the blood vessels are numerous. Now not everyone has the coral pink gingiva. Many of us have some amount of pigmentation. This is the physiologic pigmentation. This is the melanin pigment. Melanin is a non-hemoglobin derived brown pigment and is responsible for the pigmentation of the skin, oral mucosa and gingiva. It is quite prominent in the dark complexioned individuals. Now this pigmentation can be diffuse, deep purplish or irregularly shaped brown patches. They appear as early as 3 hours after birth. Sometimes this pigmentation affects the aesthetics of an individual and the individual may seek treatment for the same. The procedure which is undertaken is called as the depigmentation procedure. But this is not permanent. After a certain period of time, the melanin pigment reappears again. This is called as oral repigmentation. Consider it like tanning. When you go out in the sun, your skin gets tanned. But you get back to your normal skin tone in some time. Same is the case with the depigmentation procedure. Size refers to the sum total of cellular and intercellular elements and their vascular supply. Any alteration in the size, like say if there is enlargement, is an indication of gingival disease. The marginal gingiva should be flat, snugly fit around the tooth, whereas the attached gingiva, the width varies. It is maximum in the incisor region and minimum in the first premolar area. The contour depends on 4 things: shape of the teeth, alignment of the teeth in the arch, location and size of the proximal contact. That is, if the teeth have a contact point, then the interdental papilla will be pointed or slightly rounded. If there is a diastema or a space present between the teeth, then the interdental gingiva will be flat or saddle shaped. The contour also depends on the dimensions of the facial and lingual gingival embrasures. Now in case of marginal gingiva, there is somewhat a scalloped outline with flat surfaces, which forms a straight line along the teeth. Whereas in case of attached gingiva, the contour is a little prominent corresponding to the root contour. So if the teeth are placed labially, then the contour is accentuated and the gingiva is placed slightly apically. Whereas if the teeth are lingually placed, then the gingiva is thickened and horizontal. The shape depends on the contour of the proximal tooth surface, location and shape of the proximal contact, and dimensions of the gingival embrasures. Now interdental papilla anteriorly is pyramidal shaped, posteriorly it is flattened. If teeth are close together, then the interdental bone is thin mesiodistally, so the interdental gingiva is narrow. In case the teeth are spaced or if the proximal surfaces are flaring out, then from the area of contact, then we have a flat or broad interdental gingiva. Consistency. On palpation, you should feel gingiva which is firm and resilient and tightly bound to the underlying bone. Now this firmness is because of the collagenous nature of lamina propria and its contiguity with the mucoperiosteum of the alveolar bone. So how do you check for this consistency? Use the blunt end of the instrument. Surface texture. In case of free gingiva, the surface texture is smooth, whereas in case of attached gingiva, it is stippled. Stippling is present on the attached gingiva and the center of interdental papilla. The marginal gingiva is not stippled. So how do you check for stippling? Switch off your chair light and dry the gingiva. You should be able to see pitted surface appearance, something like an orange peel. Now, this is seen more on the facial surfaces and less prominent on the lingual surfaces. It is absent in infancy and it appears at about 5 years of age. It increases with age and disappears in the old age. Microscopically, you will see a series of alternate rounded protuberances and depressions in the gingival surface. These depressions are covered by stratified squamous epithelium. It's a form of adaptive specialization or reinforcement for function. It's a sign of healthy gingiva. Loss of stippling is a sign of gum disease. After treatment, once the health of gingiva is restored, stippling returns. Position. Position refers to the level at which the gingival margin is attached to the tooth. As the tooth erupts, the margin and the sulcus are at the tip of the crown. As eruption progresses, the margin and the sulcus they move closer to the root. During eruption, there is remodeling occurring in the junctional epithelium, outer epithelium and reduced enamel epithelium. Continuous tooth eruption. According to this concept, the eruption of teeth does not stop when they come in contact with their functional antagonists, but rather it continues throughout life. So there are two phases. We have the active eruption and the passive eruption. Active eruption is when the teeth move in the direction of the occlusal plane, whereas passive eruption is exposure of teeth by apical migration of the gingiva. This has given rise to 4 concepts. So we have the anatomic crown, clinical crown, anatomic root and the clinical root. Anatomic crown is the portion of the tooth which is covered by enamel. Anatomic root is the portion of the tooth covered by cementum. Clinical crown is the part of the tooth which is denuded of gingiva and it is projecting into the oral cavity. The clinical crown may be smaller than anatomic crown or it may be bigger than anatomic crown. So when can a clinical crown be bigger than anatomic crown? If you know the answer, comment below. Clinical root is the portion of the tooth which is covered by periodontal tissues. When teeth reach their functional antagonist, that is when they come into occlusion, the gingival sulcus and the junctional epithelium, they are still present on the enamel. And the clinical crown is approximately 2/3 of this anatomic crown. But what happens when teeth are attreated? When teeth are attreated, there is loss of tooth substance. To compensate for this loss, the teeth erupt. Now, as the teeth erupt, what happens is we see cementum deposited at the apices and furcations of roots, and there may be bone formed along the fundus of the alveolus and at the crest of the alveolar bone. In this way, the part of the tooth which is lost by attrition is replaced by lengthening of the root and the socket depth is maintained to support the root. Passive eruption is considered pathologic. There are 4 stages over here. There are two things which you need to consider. Remember about junction epithelium and the gingival sulcus. So at each of these stages, the position of junctional epithelium and gingival sulcus keeps changing. So in stage 1, that is once the teeth reach the occlusal plane, junctional epithelium and the gingival sulcus, they are both present on enamel. Then in stage 2, what happens? The junctional epithelium proliferates. So now it is partly on enamel, partly on cementum, whereas the gingival sulcus is still on enamel. In stage 3, the junctional epithelium is on the cementum. The sulcus is on the gingival sulcus is at the level of the cemento-enamel junction. So as we are seeing, it is moving apically. In stage 4, the junctional epithelium has proliferated more further away from the cementum. So the base of the gingival sulcus is also present on cementum. And this portion of cementum is now exposed. This stage is accompanied by degeneration of gingiva and the periodontal fibers and their separation from the teeth. So all this is the result of chronic inflammation. So passive eruption is hence considered as a pathologic process.